So today we're going to be presenting new information about substance-related and addictive disorders. So this is the DSM-5 category that is going to be discussed. And we're going to focus entirely on substance abuse. But under this category in the DSM-5 includes other addictive patterns, for example, gambling, or sexual addictions, or gaming is being looked at very closely as an addictive situation for some people. And it is being researched and will be included in future DSMs as an addictive possibility. So these are, there are other things besides substances that fall into this category. It is obviously a significant category where lots of people have lots of challenges with this. And so when we talk about this today, we're going to really focus very pragmatically on substance abuse specifically and what nurses need to know about substance abuse. There are so many things that could be said. And some of you probably have had classes, maybe an entire, semester-long class dealing with this subject by itself. There is that much information that could be covered. We only have 3 hours and we do have to get through it all. So we are going to very much focus our attention on what we as the nurses need to know at the bedside to recognize when somebody's struggling with a substance abuse disorder or addiction, and what we can do to recognize the symptoms of intoxication and withdrawal, what we do about it in the short term, and what we do about it in the long term. So let's go ahead and plow in and start with that. Okay, so once again, we have a table that kind of gives you your study tips. When you go to prepare for this exam, which is next Wednesday, you're going to be asked specifically to differentiate between substance use disorder and substance-induced disorder. And we'll talk about that more in just a minute. And also identify factors that contribute to why people struggle with substance use disorder. And then the majority of the test is going to be, again, very clinically focused. Knowing the various categories or classifications of the drugs that can be abused, depressants, opiates, stimulants, hallucinogens, and what drugs fall under those categories. And then recognizing the symptoms of what a patient would look like if they came in intoxicated to that substance, what it would look like if they withdrew from that substance, and what we as nurses will do to support them during their intoxication and withdrawal, and then also follow-up care, trying to get them into drug rehab and that type of thing. Any questions before we plow in to our new topic? Okay, let's go ahead, and please don't hesitate to, pop anything into chat as you have comments, or if you have interesting facts that that you want to contribute, please do so. This is a topic that many of you have, some expertise on, perhaps. Perhaps, like we said, you've had other classes or have had opportunities to work with people in this dynamic. And so if you want to add your comments in the chat as we go along, that's great. Okay, so let's kind of delve into it. As we said, there were two terms that DSM-5 is presenting that you need to be able to distinguish between them. The two terms are substance use disorder, and I want you to write next to that addiction, because that's what substance use disorder is. We called it addiction in the past. They're calling it substance use disorder now, but they are one and the same thing. And then the second term is substance-induced disorder, or in other words, things that happen because you took the substance. So let's talk about each of these independently. The first one is the substance use disorder, or the addiction. If a person is using a substance in a way that actually is leading to addiction, they have some of these kinds of symptoms going on. They're using the substance to the point that it's actually interfering with their life in meaningful ways, right? You don't have a disorder unless life is being interfered with significantly. So they're having difficulty fulfilling their roles and obligations at work, at school, at home. They would like to cut down and control their substance use, but find it very difficult to actually make headway with that. They have very intense cravings. We'll talk more about cravings and why that plays such a role and why it's hard to get over the use of substances. Problems with interpersonal relationships, where people are being very isolated and they withdraw from family and friends, focused on getting their next dose of the substance. And they will often compromise family relationships and friendships and stability in life in order to get the next dose of their medication or the drug that they're abusing. Recurrent substance use in situations where it is physically hazardous. So they don't have good common sense. They drive when they're intoxicated. They are working as a nurse when they're intoxicated. How many of you have actually had that experience already where you are aware of a nurse coworker or perhaps a doctor, another healthcare provider who has come to work and they're intoxicated or they're compromised because of the use of some type of substance? Just throw in the chat room if you've seen that already. I hadn't worked for very long in my first job, and ran into it both with a fellow nurse and with a doctor. And so it was very scary. And as I can see, you're typing in, yeah, it's not unheard of. Some of you have experienced this already. And I've seen it several times too. And what's kind of sad is that, at least for my experience, the nurses who were struggling were some of the best nurses. And one of the traps we fall into as nurses is we see ourselves as caregivers. And when we need help, we don't know how to get it for ourselves. We don't know how to let other people in and admit to people, you know what, I need to be the one who's taken care of. I'm struggling in life. And so sometimes people will turn to substances as a way of trying to carry on, to cope, and then they get trapped in that addictive process. For me too, Braden, it was the most severe case I saw was a nursing supervisor, and she was known to be the best nurse on the floor. So pretty devastating, and none of us are immune. We need to be careful with this. Also, just as an aside, if you are aware of a nurse who is abusing a substance, it is your ethical obligation to report that to the appropriate channels in the place that you work so it can be explored and discovered. So obviously they can get into legal problems. It was mentioned by Kylie that the person got fired. Sometimes their license will be at risk. Interestingly enough, state boards of nursing look at each case individually when there is abuse. And if the person abused in a way that didn't harm the patient, so for example, I had a fellow nurse who would take the patient's Percocet and Loratab. And how it was discovered is the pharmacy noticed that when she was working, her patients needed far more of these medications than they did the shift before and the shift after. And of course, she was pocketing the ones she wasn't giving to the patient. So the pharmacy figured it out. They investigated, and indeed, she was stealing the medications from the hospital, but never did it in a way that harmed the patient, meaning the patients got the meds they needed to be comfortable. They were just getting charged for more medications that she was taking home. I've also seen cases where that's not the case, where a nurse was actually substituting out, replacing with normal saline, at that time it was Demerol, so it was an older drug, and then it would be inadvertently given to patients, obviously very harmful, and or in a way that hurt the patient. So State Board of Nurses look at this, and if it doesn't harm the patient, they often attempt to work with the person, get them through rehab, give them a conditioned license. So for example, the gal who was taking the Percocet who did not actually harm a patient was allowed to continue working, but she couldn't ever have access to the narcotic keys, and another nurse had to give all the narcotics to her patients for a full year while she went through rehab. And then she had to have follow-up after that, and of course was on her record, so she was watched very carefully. So Yeah, so great stories. Thanks for sharing these stories with us. So obviously the nurse that was harming patients, her license was taken away by the state board. So it's individually decided, and they try to work with people if it looks like they can be worked with, so as to not take away their livelihood if possible. So that's just a little aside about our obligation to report if we see somebody who is potentially compromised. So, substance-induced disorder. So remember, substance use disorder is addiction and all the symptoms of addiction that we just discussed. Substance-induced disorder is what happens to the person physically because they're taking the substance. So the first thing we might notice is they might take too much of the substance and become intoxicated. If you are intoxicated and you become dependent on the drug, you may go through withdrawal symptoms. So those are two physical responses that are induced because you were taking the substances. Other ones include substance-induced psychosis. So what that means is, you remember how when we talked about schizophrenia, that we realize that hallucinations and some of our delusions, false fixed beliefs, are related to that dopamine dump in certain areas of the brain. So there's an overabundance of dopamine in the brain. Any substance that's abused, and we'll talk more about this in a minute, any substance that's abused ultimately, through one way or another, leads to a dopamine dump in the pleasure centers of the brain. So people who are at risk, genetically, other ways of being at risk or vulnerable to the potential of developing psychosis or schizophrenia, taking drugs induces it. And so they have psychosis sometimes when they're intoxicated, but then what's more scary is that it might last and may never go away. So they took the marijuana, for example. There is a high association between marijuana use and the substance-induced psychosis in vulnerable populations. They take the marijuana causes them to be high, and then they go through withdrawal, and then the drug gets out of their system. But the psychosis that started at that time remains, and it never goes away, and they get the diagnosis of schizophrenia. So we sometimes see that schizophrenia is triggered by having used drugs in the past. Now, I use marijuana as an example, but it's all of the substances that run that risk because they all cause a dopamine dump. Other manifestations: delirium, amnesia, mood disorders, anxiety disorders, sexual dysfunction, sleep disorders. So again, anytime you have a physical problem that results because you were taking these substances, then that's called a substance-induced disorder. Does that make sense? Does anybody have any question in distinguishing between those two? I hope you realize that I'm making a big deal of that because probably you'll have to distinguish that on the test. So let me know if you have any questions on how those are this different. Okay, now let's talk about substance dependence. People who struggle with substances can be physically dependent and or psychologically dependent. So physical dependence means that the person has become accustomed to the drug being in their system, in their body, and their body has developed a dependence on having that drug in the system. Psychological means that they have used the substance and it's produced a pleasurable effect and they start craving the drug. Eventually, as people use drugs to excess, they no longer get the high or the good feelings associated with taking the drug that they originally had when they started using the substance. Rather, they have to take the drug to avoid the symptoms of withdrawal in order to not feel terrible. And cravings are a part of this because you make associations where you were, the drug paraphernalia, all of these things give you memory cues. And these memory cues cause you to desire to crave the drug that you've become addicted to. So let me give you a story of how this can look. So this is actually a fairly common scenario that we as nurses would want to watch for. This was a gentleman who had a slipped disc or a herniated disc in his back. Anybody had that wonderful experience or know somebody in their family who's had a herniated disc? If you have, what is the biggest symptom they experience? Yeah, it's pain. I mean, big time pain. They can't move. They can't get in and out of bed without excruciating pain. It's uncomfortable to sit. It's uncomfortable to change positions. They can't stand up straight. It hurts so bad. They have pain, sciatic nerve pain going down their leg. Very, very miserable. So it is a fairly common problem, and our insurance companies, which claim they don't practice medicine but dictate to doctors what they can and cannot do, insist that people with a herniated disc go through medical treatments before a surgical option. So this particular patient went through a couple of steroid injections in his back that failed, meaning they didn't help. And during this whole month and a half, while he's going through these medical options to try to resolve the herniated disc, the physician is giving him Loratab around the clock to try to help keep this pain under control because he's in excruciating pain. Ultimately, it's determined that he's a candidate for the surgery. He goes in and has the surgery on a Friday, does very well with it, comes out from the surgery, and this is not uncommon, so this just tells you how bad this pain can be. Comes out from the surgery claiming the pain is so much less than it was when he went into surgery. So post-op pain is far less than the actual pain that took him to surgery. And he's heard all of the stuff that's advertised everywhere. You don't want to be, you don't want to get addicted to an opioid. So he goes home, he thinks, I'm not in that much pain. I'm not going to take any more of my Loratab. Instead, I'll just take, Tylenol and the Motrin that they've suggested, and I'll just stop my Loratab because I don't want to get addicted to it. And about 48 hours later, he is so anxious, he can't sit down. He's overwhelmed with anxiety. He's having diarrhea. He feels like he can't catch his breath. He's just overwhelmed with distressing symptoms. Okay, so what has happened to this man? Is he physically dependent? And if so, how do you know? And is he psychologically dependent? And if so, how do you know? Okay, physical because of the symptoms, absolutely. The only way you know you have physical dependence is when you stop the drug. And if you go into symptoms of withdrawal, that means you were physically dependent. So you only go into withdrawal symptoms if your body actually became acclimatized to the drug and you became physically dependent about it. Psychological because of anxiety. Interestingly enough, the anxiety is the physical symptom of coming off the drug and is associated with the physical dependence. So thanks for sharing that, Megan, because that's an important point of clarification. Anxiety is associated with the physical symptoms of becoming intoxicated and withdrawing, and the overwhelming anxiety is a part of that, and we'll clarify that even more when we talk about opioids. You would have known he was psychologically dependent if he craved and wanted the medication and desired it and had cravings for it. But he didn't, right? He was willing to stop cold turkey, which indicates he had no psychological dependence because he had no feelings or desires to take the med other than to control the pain, and now he didn't have pain, so he didn't want to take the med. So he actually did not have any psychological dependence. So that's an important distinction. Thank you for bringing those comments up so we could clarify those things. So this is very common, as you can imagine. When we put people on drugs, and of course it's the weekend, right? So he's suffering over the weekend, doesn't understand what's wrong, doesn't realize it's because he stopped his Loratab, is very miserable over the weekend. By the time Monday rolls around, he calls his doctors. The symptoms are starting to subside and go away because he had been on the drug for a short period of time, meaning a month, month and a half. The withdrawal symptoms, although powerful and distressing, only lasted a couple of days. If you have been on drugs for years, your withdrawal symptoms take a lot longer to overcome. One thing that will always happen with physical dependence is you will get sleep disturbance. And that can go on for months, as it did for this gentleman. He got over the other uncomfortable symptoms of the physical withdrawal, but he had insomnia for over a month before he was able to sleep through the night again. And that's a very common thing with withdrawal from any of our medications, this insomnia. Any clarification? Has that made sense to people? Okay, thank you, Ashley. Okay, etiology of substance-related disorders. So as you're looking through these, I want you to kind of do a little self-evaluation and see how these factors have influenced your view of substance use. Substance use is very common throughout the world. We use all kinds of substances. Some fall into the category of things that could be abused, but others are your viewpoint on vitamins varies with some of these same factors. How you were taught to think about them, and are they valuable or are they not valuable? These kinds of things really influence the use of substances, individual use of substances. So one thing that we do know and have recognized, especially for people who are struggling with addiction, is that there's often a genetic tendency. And that is a very important component of what sets some people up to really struggle with drug abuse. And some people recognize very early in their use of a substance that they are becoming very psychologically connected to wanting the substance, and that may have a genetic tendency. We also know that there are neurotransmitter disruptions. We just spoke a moment about it, that when you use any of these substances, it causes a dopamine dump in the pleasure centers of the brain, and that can play a role in having issues with developing substance use disorder. We also know that personality factors can play a role in developing addictive behaviors. If a person has low self-esteem, they're frequently depressed, passive, inability to relax or delay gratification, ability to communicate effectively, or antisocial, they may turn to drugs as a way of kind of self-medicating through these uncomfortable feelings. Matter of fact, this is very common with mental health disorders. The number one comorbidity for any mental health disorder is substance use disorder. And that's because people treat themselves with drugs they can get access to as a way of coping with their feelings associated with their mental illness. So the comorbidity of substance use disorder with schizophrenia, with bipolar disorder, with depression, with these other things is very, very common. And so when we assess our patients with a mental health disorder, we always want to carefully assess to see if they're also having a struggle with addictive disorders. Social learning, what was modeled for you? What did your parents do? What did family members do? What did they show you? What did they include you in? What were their viewpoints that they passed along to you? Conditioning, when you use a substance, if it brings pleasure, if it brings relief to stress you're having, that kind of conditions you to want it more in the future. And then there are cultural and ethnic influences that mold your attitudes, and availability plays a role. People abuse what's easily available. So in our society, what do you think the drug that's most abused is based on that principle? It's alcohol, and it's becoming closely followed by marijuana. So if any of you were thinking of that, you're not far off. As that has become legalized in many places, and as it has become seen as for medicinal purposes, it has become more available and is now being more used, and we're seeing more issues with drug substance use disorder, with marijuana being the drug that is being abused. Okay, so another general principle about all of our drugs of abuse. All of them increase dopamine in the pleasure reward center of the brain. Now, when you take your pharmacology class, you will get into how it accomplishes that, because that seems a little contradictory. Some of our drugs, like alcohol and opioids, are central nervous system depressants. They're slowing down the brain. And others are stimulants, like methamphetamine, and they're stimulating the brain. Well, those are two opposite effects in the brain. So how is it they both are addictive, and how is it that they both trigger dopamine release? Well, some of them do it directly. Stimulants just directly stimulate dopamine to be released in your brain. But the central nervous system depressants and hallucinogens and other categories of drugs of abuse still trigger excessive amounts of dopamine in these areas of the brain. They just do it in an indirect pathway. So they go through some other paths, but in the end, they too dump dopamine in the brain. And so the take-home point at this very beginning presentation is that all drugs of abuse cause a dopamine dump. And that dopamine dump is what makes it pleasurable, desirable, gives you the euphoric feeling, and makes you want to use the substance again. When it's very high levels of dopamine, you can see that they actually get some symptoms that are associated with really abusing a substance. Euphoria, hallucinations, poor judgment, and memories that form cravings. And those memories that form cravings are why relapse is so prevalent. And we'll talk a little bit more about that too as we go along. Tolerance. It's important to understand the concept is tolerance for nurses. Unfortunately, some people in our society don't understand this, and this can lead to some very serious consequences. When a person starts using a drug of abuse, the initial time they use it, they get that dopamine dump. It's a sudden dump, and it causes a very high pleasurable response, and it's very reinforcing. Over time, however, your body becomes accustomed to this drug being in your brain, and it doesn't give you the same high that it did when you first started using it. So in order to get that same euphoric feeling, you find that you have to use more and more of the drug. That's called tolerance. And as you build up that tolerance and your body gets used to the chemicals in your brain being present a lot and most of the time, people start having less of a feeling of euphoria, and they have become physically dependent on the drug. So now they start to abuse the drug in order to prevent feelings of withdrawal, which are very miserable, and that's what keeps them going. Did you have a question? I think it was Shelby that popped up there. If you do, please jump in and ask your question. So tolerance is something that happens with all drugs, and including drugs of abuse. Now, this is what can be concerning. The person decides or is brought in and undergoes treatment, and then the tolerance fades. And after about 10 to 14 days, their brain is back to being more used to not having the drug on board. And if they return to taking their drug the way they did when they stopped using it at a very high dose, they can sometimes overdose and die. I actually had this happen to a friend of mine. Her son and his best friend were using narcotics, opiates rather, and had become addicted to them. And her son had ended up in the ICU, almost having overdosed on them at one point. And his friend and he went through rehab. And they went through the withdrawal symptoms. They were in the rehab process. And the friend went back and socialized with friends who were still using drugs. And of course, he got talked into using them again. And believing that he needed the same dose he'd used the last time he'd used the drug in order to get that high, he took that very large dose. And unfortunately, he went to sleep. People weren't paying attention to him. He stopped breathing and he passed away before anybody noticed that he had overdosed on it because it was the same dose he'd used before the tolerance had faded. And now it was a life-threatening dose. Does that make sense to people, what I'm talking about with tolerance here? Any questions on tolerance? Right. Okay, thank you. Okay, so this is the classifications of the drugs of abuse. And there are 5 main categories, and you do need to know these classifications, and you do need to recognize the names of the drugs and which classification they belong in. Because when people come in, they tell us about their alcohol use, or they tell us that they're using Valium a lot, or they tell us that they're using cocaine. We need to be able to recognize from the name of the drug they present what classification of drug it is. Because as you'll notice when we go further in this discussion, we're going to learn about the signs and symptoms of intoxication and withdrawal based on the classification. Because it doesn't really matter whether you're becoming intoxicated with alcohol or if you're becoming intoxicated with Xanax. They're both central nervous system depressants. So the signs and symptoms of intoxication will be similar, and the signs and symptoms of withdrawal will be similar. So you need to make this connection. So if you don't have a background that gives you a lot of familiarity with this, please look at this table closely so that you'll be familiar with it. So the 5 categories are depressants, opioids, stimulants, and hallucinogens. And that's what we're going to do in the next 2 hours. Go through each of these classifications, discuss the challenges of intoxication and withdrawal, and what we do for patients who have these struggles. Okay, so let's go ahead and start with the first one. The first one that we're going to talk about is alcohol use disorder. So it is a central nervous system depressant. In other words, it slows the brain down. And so when we're using it, that's what the symptoms we're going to see when somebody becomes intoxicated. Just some kind of background information on this. It is the most widely abused drug in the US. It's the 3rd leading cause of preventable deaths, and I'll let you look through and see how that's associated. And then it's also unfortunately associated with fetal alcohol syndrome, which is the most common preventable cause of intellectual developmental disorder in children. So it has a big impact in our society. When we talk about alcohol, it is going to be used as the template for when we talk about this central nervous system depressants. And the reason it's the template is because it's the most commonly one abused. But I'm also going to integrate in this discussion principles that apply to all drugs of abuse. And the first principle I want you to understand is that dose matters. So you can see that if a person occasionally has a drink, has an occasional dose of alcohol, that the impact on their body, both in the short term and the long term, is going to be far less than somebody who is having daily large amounts of alcohol, or in other words, has a large chronic dose of alcohol. They're going to have far more immediate symptoms, and they're going to have far more problems with chronic health problems associated with taking the alcohol. So hopefully that makes sense. That's true for alcohol, but it's true for everything. An occasional user of marijuana probably doesn't have much impact in their life about that. But somebody who uses it daily in large amounts is going to have both the short-term and the long-term consequences of using that medication to a greater extent. So think of any drug of abuse. That's going to be a true principle for cocaine, ecstasy, anything you can think of. That's going to be a true statement. Dose matters. Does that make sense to people? Because when I'm going to keep referring to this and just throw out the term, dose matters a lot in this lecture. Do you understand what I mean by dose matters? Okay, so that's very critical. When we take a history of drug use, we need to be paying close attention to dose and what they're using. So with alcohol, it is important to understand what one dose is, because there's many ways this could be dispensed to people. And so we have a uniform way of looking at it when we talk to patients so that we can all be on the same page when we're referring to dose. So beer, a 12-ounce fluid ounce beer is 1 drink. Wine is a 5-ounce fluid ounce, And then distilled spirits is 1.5 fluid ounces. So those all equal 1 drink. So it doesn't really matter how much a person pours in a glass. The fluid ounces is what makes it 1 drink. Heavy drinking is defined for women and men older than age 65. Different beers have different levels of alcohol. So would that change it? Yes, it does. And so you would need to look at how much alcohol is in the beer. Generally speaking, there's still less than other forms, but that could play a role. So yes, that would be something that's looked at. Women and men older than age 65 that have more than 3 drinks on any day or more than 7 drinks in a week are considered to be heavy drinkers. And men age 65 and younger who have more than 4 drinks on any day or more than 14 in a week are considered heavy drinkers. So what is the alcohol content for a 12 ounce? I would actually have to look that up. That's not something I know off the top of my head, but there are equivalency tables that you can look that up for. Thank you for asking that. And if somebody else out there knows the answer to that, go ahead and type it into the chat for us. Binge drinking. Women, 4 or more drinks within 2 hours, and men, 5 or more drinks within 2 hours is a binge drinking. Now, heavy drinking isn't necessarily translated into somebody who's considered to be addicted, but it is indicating that their patterns of using, in this case, alcohol, is on the edge of being a problem. So we'd want to watch closely to see if this is starting to interfere with their relationships, their work, they're getting into legal problems, if they're trying to cut down but they can't, all of those kinds of things. Another thing that's very important when we take a drug history for our patients coming into the hospital is that ER nurses are very tuned in. First responders are very tuned in to checking for drinking patterns and for substances of abuse that might be impacting what's going on with their patient. But nurses who work on the floor are seeing the consequences of this and may not be recognizing it. So, for example, I worked oncology for many years, but I recall several patients who'd been on our floor for a day and a half, 2 days, and then started going into withdrawal from their substances of abuse. Sometimes it was alcohol, sometimes it was street drugs. And so nobody knew, because they came in, they were admitted by their physician for surgery or whatever it was that they were admitted for. And nobody was aware that they were using a substance so much that being without it was going to cause physical withdrawal symptoms until the symptoms themselves started showing up. So that should be on our radar when we're caring for any patient, that if something doesn't match the picture, they're here for an appendicitis and they're getting symptoms that don't look like somebody recovering from appendicitis, could they be withdrawing from a substance they're not able to get where they're in the hospital? So keep that in mind. Okay. Alcohol intoxication. So this is another core principle that's going to apply to all drugs that we're going to talk about, drugs of addiction. We're presenting it under alcohol, but it's going to apply to all of them. The reason you need to know the drug classification is because the classification tells you what happens when the person is taking the drug. So we know that alcohol is a CNS depressant. So obviously, if you take a lot of alcohol, you get a lot of CNS depressant effect. The more, the heavier dose, and the more of it, the more CNS depressant symptoms you get. So when you're intoxicated, you get more CNS depressant symptoms. When the drug stops and your body starts to clear the drug from the system, and that drug starts to come back down, you go the opposite. And the withdrawal symptoms are the opposite of CNS depressant symptoms. And so you go into an overload of CNS stimulation. So let me say that one more time. Intoxication is more of whatever the drug classification is supposed to be doing. In this case, it's a CNS depressant. So when you're taking a lot of it and you're intoxicated, you get a lot of CNS depressant symptoms. When the drug is stopped and clears the body and you go into withdrawal, the symptoms go the opposite way. And the symptoms of withdrawal are the opposite of what the therapeutic effect of the drug is, which is in this case going to be a CNS stimulant. Does that make sense to people? Oh, I'm losing some of my chat here. So you guys are responding. I'm not seeing him. Let me pull that down. Yes. So that's an important concept because that's going to be the opposite with stimulants, right? When you have a stimulant in just a minute, a stimulant, when you're intoxicated, you're going to have a lot of CNS stimulation. And when you withdraw, it would be the opposite. We go into severe CNS depressant symptoms. So it's always going to be the opposite of whatever the classification claims the drug does. Okay, so let's look at this then. If the person's intoxicated with alcohol, and alcohol is a CNS depressant, then initially, as they start drinking, they become kind of disinhibited and impulsive. Their frontal lobe isn't communicating well with their limbic system. It's hijacking the brain, and they don't have the good judgment they would typically have to make, sound choices. They do and say things they wouldn't otherwise do. They have poor judgment, decide to drive home because after all, I don't have any problem anyway. And then if they continue to drink and they get more CNS depressant, then we see some of the real impairments coming on, like slurred speech, lack of coordination, unsteady gait. And, in its worst case scenario, they go to sleep and they have a blackout, right? If it's extreme. So alcohol intoxication, a lot of CNS depressant symptoms coming on based on the dose they're taking. So withdrawal would be the opposite. They're going to the drug is going to suddenly stop. And then 4 to 12 hours later, they're going to start having symptoms of CNS stimulation because those are the withdrawal symptoms when the drug is no longer on board. Now, this table that I'm going to talk about next is very important for you to know. And right before I turn this slide, let me just say this. If a person is a chronic alcohol user, they have built up a tolerance and they can have amazingly high blood alcohol levels and seemingly not have a ton of symptoms over those because their body has developed tolerance. So you can't rely on the blood alcohol level when a person is withdrawing from alcohol to determine what's going on. You rely on the actual signs and symptoms you see. What I mean by this is if it's a chronic alcohol user who's been drinking a ton of alcohol, but they haven't had any alcohol for the last 4 to 12 hours, they might start developing some of these signs and symptoms because they've had a drop in their high blood alcohol level to a lesser blood alcohol level, and that drop is what's giving them the symptoms. So they may still have a blood alcohol level, but the drop has given them symptoms. If something I'm saying doesn't make sense, it's really hard for me not to be able to see you to see if what I'm saying makes sense. Please pop in and ask a question. So symptoms can happen if they, because of the drop in the alcohol level, is what brings on the symptoms of alcohol withdrawal. And they start within this 4 to 12 hours. And the worst case symptoms would be delirium tremens, but those symptoms don't occur until 4 to 5 days later. So this is an important to know table because this is what we're going to see if somebody is withdrawing from alcohol. And I want you to notice that there are 4 stages. Stage 1, 2, and 3 all happen within 4 to 12 hours of stopping drinking and a sudden drop in the blood alcohol level. Doesn't have to go all the way back to normal, but you've had a sudden drop in your blood alcohol level. The first stage starts between 4 to 12 hours and can last up to 72 hours. And the person, it's often called the shakes because that's the primary symptom people experience. They feel shaky, they have rapid intentional tremors, they can't Their hands are shaking when they try to pick up a glass. They feel very anxious. Again, that anxiety is often associated with withdrawal of many things. Very, very anxious. GI distress with diarrhea. Mild ANS effects, so their blood pressure is going up and their pulse is going up. So they're going into CNS stimulation, right? Everything's working too much as part of the withdrawal symptoms. That's a very common scenario. People who, binge drink, they binge all weekend long. Monday morning, they feel terrible. They feel shaky. They feel awful. They kind of live through their, 12, 24 hours, however long it takes them to get past feeling this shaky stage 1 feeling. And then they're good to go again and they're back to normal. So nurses rarely see people come to the hospital for stage 1, but it is experienced a lot by people who are drinking to excess, or by our chronic alcohol user who isn't able to drink as much as they want to be able to drink to stop feeling these symptoms. Stage 2 and 3 sometimes brings people to the hospital. Notice that the timing on that is the same as stage 1. These symptoms start developing between 4 to 12 hours, and they can last up to 72 hours. And these people have what are called alcohol hallucinations. So they're usually visual hallucinations. They see something in the room, but they kind of have a distinct quality that makes them different from somebody who's psychotic, like schizophrenia. And that distinct quality is that they remain very oriented and can tell you everything that's going on around accurately, but by golly, there's a pink elephant in the corner of the room and you can't talk them out of it. So in that sense, they're not buying into the hallucination like a schizophrenic is, in the sense that remember, schizophrenics often felt engaged with their voices and what they were hearing or seeing. These are almost always visual hallucinations, and the person adamantly can see it and believe it's there and will tell you about it. But everything else, they'll answer questions correctly. They also often have tactile hallucinations, meaning they feel things are crawling under their skin or something distressing of that nature. And paranoia. They're, sure that, the husband and the wife, somebody is, picking on them and making life hard for them. So this is interesting. They thought there was an alligator in the corner, kept having to be reminded that there wasn't one. Yeah, that's a very great example. So stage 3 also has that same time frame, and this can be an abrupt onset of clonic-tonic seizures. In other words, a grand mal seizure, a full body seizure, not partial seizures. And they may have 2 to 3 episodes within a 6-hour period. But what makes this different than somebody who's usually having problems with epilepsy is that they'll have the seizure, but they wake up pretty well after them, and they're quite lucid between the seizure episodes and seem to do quite well between the seizures. Interestingly enough, if you've had a history of seizures in the past when you're withdrawing from alcohol, it does not predict whether you'll have them in the future. You kind of think it should, but it doesn't. There's no correlation. Sometimes people have them, sometimes they don't. So not having a history of it doesn't mean they won't have it this time either. So we're just going to watch everybody for the potential of seizures. So pseudo-seizures are not related to this. These are not faked seizures, they're real seizures. Pseudo-seizures is what's called a conversion disorder, and you're going to be talked to about that in your RN year. And it is a dissociative state. It's a mental illness, and it's when people fake seizures for secondary gain. And when I say fake seizures, they're not intentionally faking the seizure. They don't actually know they're faking the seizure. They're doing it to try to get out of a very difficult emotional situation. So for example, if a young boy sees his parents fighting, and they're pretty violent in the way they fight with each other, and he feels very helpless about it, very distressed about it, tries to intervene, his father reacts, in a violent way towards him. He feels helpless, distressed. He might have a conversion symptom. So for example, he might start having seizures right then. Now, he's not thinking to himself, I'm going to have seizures to distract my parents. There's no thought of that kind. The seizure is as real to the patient as any seizure is to any patient as far as his experiencing it. But when they do an ECG on it, there's no electrical wave differences. So it's not a true seizure from a neurological standpoint, but it is a psychological seizure. If the parents are fighting and the son starts having a seizure, what do the parents stop doing? Well, they stop fighting and they start focusing, hopefully with some love and attention, on this child. So it got them secondary gain. So I hope that helps clarify it. That's a little bit of an aside, but it's not what we're experiencing here. People with alcohol withdrawal can and do have real seizures, and they usually are short-lived within this time frame. And we just make sure that we give supportive care through them, and then they're gone. They don't have them again because the drug's out of their system. Now, notice that stage 1, 2, and 3 could all happen during the same time frame. The reason this is so important is because, alcoholics are known for drinking to excess, having an uncoordinated gait. It's not uncommon for them to fall and hit their head. So that kind of clouds the picture for the physician who's trying to make the diagnosis of what's going on. And they wouldn't want to just dismiss somebody's seizures as alcohol withdrawal, when in reality they have a brain bleed from a fall and we're now missing some important symptoms. Or perhaps their blood glucose has dropped really low and we're missing something we should have caught. So this pattern is very important to know. If it's due to the alcohol, stage 1, 2, and 3 will look like this description. If it doesn't look like this description, the physician broadens their differential and considers other possibilities for why some of these symptoms might be occurring, and doesn't limit themselves to just kind of saying, oh, they're in alcohol withdrawal, they'll get over it pretty soon. Now, the treatment for all 3 stages is the same. We give them benzodiazepines, and it doesn't matter which benzodiazepine, if it's Valium, if it's Xanax, if it's, whatever one they're using. Because benzodiazepines help the person who's in that CNS stimulant state kind of calm down, right? Because benzodiazepine is a CNS depressant. So it kind of calms them down. It makes the symptoms not be as bad. It may keep them from having further seizures. It might make it so that they're not as paranoid, that they can rest and sleep and kind of get through this stage until this withdrawal symptom kind of abates. It helps them not feel so shaky. It gives them, it brings their blood pressure and pulse down a little bit as they relax. So it kind of treats the symptoms. Another important reason for giving benzodiazepines through these stages, if they're in our care, is because this helps prevent the truly scary withdrawal symptom of alcohol withdrawal. Stage 1, 2, and 3, whether they came in for health care or not, they're going to survive them, they're going to get over them, and they'll probably be fine. Stage 4, however, is delirium tremens, which could be life-threatening. This happens 4 to 5 days after the alcohol has been stopped. So that's an important thing to note. Feeling shaky a day or 2 after you stopped your alcohol is stage 1. It's not delirium tremens. It has to be 4 to 5 days later, and your brain just can't sort it all out. And you kind of have ANS disruption that leads to all of these symptoms of significant hypertension, tachycardia, confused, diaphoresis, wild, profound hallucinations. So they're not just casually saying, there's that elephant in the room. They are wild with hallucinations, trying to get the bugs off them, trying to get the snakes out of the room. And this is potentially life-threatening. Matter of fact, in the past, before we had better treatment, 50% of people would die of their delirium tremens. So pretty bad scenario. These people are put in the ICU. They're given supportive care, which includes benzodiazepines. And hopefully we get them through it so they can go into rehab. If you treat people in stage 2 and 3, 1, 2, and 3 with benzodiazepines, you decrease the chance that they'll go into delirium tremens. So physicians are pretty generous with the benzodiazepines if somebody comes into the ER with stage 2 or 3, not only to keep them comfortable during those stages, but also to prevent delirium tremens if possible. Any questions about this slide? We've spent a lot of time on it. It's an important one. Okay, just a couple more comments, then we'll take our break. Complications of alcohol abuse, again, are dose related, but this is just a slide showing you that beyond the intoxication and withdrawal, people have a lot of chronic problems associated with alcohol abuse over time, especially our chronic users. One of them is that they have a lot of vitamin deficiency because they drink their meals instead of eating their meals. And over time, they get very deficient in vitamin Bs and also thiamine. So you just need to be familiar with these terms to know what they mean and that they're associated with vitamin deficiency. And so one of the things we want to do when we have somebody we know is an alcoholic in our care is to give them vitamin replacements. If they can take it orally, that's how we give it. If they're not taking it orally, we may hang an IV bag to give them vitamins while they're in our care to get their vitamin count up better, decrease the potential of these chronic complications. Just so you know, if you put vitamins in an IV bag, it turns it bright yellow. So you may have heard people refer to this as a banana bag because it's a bright yellow color. So that's just kind of an interesting aside. There are other chronic complications of alcohol abuse, and here's our whole list of them. Notice how distressing it is to the heart, to the GI tract, to your bloodstream. You've got leukopenia, thrombocytopenia, sexual dysfunction. We all know that you can have alcoholic liver and cirrhosis of the liver. So what we're just saying is that in addition to intoxication and withdrawal, knowing that table well, you need to realize there are a lot of chronic health problems for people who are chronic users of alcohol in an abusive way. Okay, any questions on alcohol use disorder? Okay, time for a quick break. Let's take our 5-minute break until 10:01, and then we'll start up on our next one. Okay, welcome back. So now let's go ahead and talk about opioid use disorder. And opioid use disorder is very problematic, obviously, in our society. And so we're going to take some considerable amount of time talking about it and what's going on with it as well. It also is a CNS depressant. The reason it has its own category is because we want you to recognize which drugs are actually opioids because of this opioid crisis we're in. So we want you to be able to recognize that. We know that prescription narcotic abuse, more than all other illegal drugs put together, are a result of this. Utah is the 4th in the nation for abusing pain medications. More people die of accidental overdose with prescription pain medications than from motor vehicle accidents. And popular drug because they desensitize an individual to both the psychological and physiological pain and may induce a sense of euphoria. Number 4. I'm not sure what you mean by that, Amy. Can you clarify just a little bit? Oh, 4th in the nation. Yes, and I actually haven't looked at that. I should have looked at that before I put this on today, but we're always very high, and it has been a little bit since I looked at that particular one, but we're always around that number. We have been for a number of years. So yeah, we're not immune to it here, and we need to be aware of that. So notice I put in red down here, there's a learning activity video to view. This is the one, your learning activity today. And I think it's 30 minutes, it's not more than 30 minutes of a video that was produced at Weber State University talking about the opioid crisis, how we as a medical profession kind of helped to create this problem unknowingly, right? It wasn't something we didn't intend to do, but happened nonetheless. And it also shows common stories about how this happens in our society, how people get trapped into this, and what the interventions for somebody in an opioid addictive situation is. So this is a critical learning activity that you're going to want to make sure that you look at closely today. It closes at midnight tonight, in preparation for next week, because it's going to give you a lot of background information that I'm not going to take the time to present right now. Okay, so back to the same idea. Opioids are a central nervous system depressant. So if you take too much, you depress the central nervous system more. If you withdraw, you stop the medication, you start going through withdrawal, the opposite symptoms occur, and your CNS becomes stimulated. So in opioid intoxication, initially, the reason people take it is they feel some euphoria, like they do for all drugs, because of that dopamine dump. And then you start getting the CNS depressant symptoms of dysphoria, psychomotor agitation, impaired judgment, drowsiness, slurred speech, impaired memory and judgment. And what makes opioids even a little bit more scary than some of our other CNS depressants is that it actually has the ability to depress your respiratory system and you stop breathing, right? That's why those who are first responders and family members of people who are addicted to opioids are now given Narcan, which is a medication that can reverse the opioids quickly and to bring them out of respiratory distress if they're found to be not breathing or breathing very little. So death is a possibility. And I don't know, you might chime in and let me know if any of you know people personally who have died of an opioid overdose. I actually had a neighbor die of this back before anybody even realized what a crisis or problem this was. This was many years ago. And got just the traditional story, started on by the doctor for severe pain. I can't remember what was the cause of his pain, then couldn't get free of them, and was found having overdosed inadvertently at home by his wife. It was very sad. So this is a very scary potential, and that's why we want that Narcan to be available to family members and first responders so they can turn this respiratory distress around quickly. So opioid withdrawal is going to be the opposite. Now we're going to go into CNS stimulation because withdrawal is the opposite of the therapeutic use of the classification. So again, anxiety, difficulty sleeping, insomnia, yawning. Remember, everybody who withdraws from any drug has difficulty sleeping. They can have sweat, chills. Piloerection is the medical way of saying that you have goose flesh or goose pimples. GI cramping, diarrhea, vomiting. You kind of realize this. If you have somebody who's on Loratab for pain following surgery, we know that it makes them sleepy. We know that it makes them kind of feels groggy and slowing down. We know that it slows down their GI tract. We worry about constipation. Those are all the things that would happen during intoxication. That would be more extreme. And then when they go through withdrawal, the opposite happens. So now they're going to have diarrhea, vomiting, runny nose, teary eyes, pupil dilation, some fever sometimes with muscle aches can happen as well. So the treatment is Narcan in the moment, especially if their respirations are being affected. When they're going through the acute withdrawal symptoms, when they are extremely anxious, when they can't sleep, when they are feeling chills and fevers and muscle aches, to help reduce those symptoms, they can be given benzodiazepines. So again, this kind of matches the other CNS depressant withdrawal kinds of situations and things that we do for them. We want rest and nutritional support. And then ultimately, and we didn't emphasize this too much with alcohol, but of course it's true, once we get the patient past the initial crisis, we're always going to follow with some kind of rehab for people who are struggling with abusive disorders. And so 12-step programs are known to be the best as far as helping people get off a substance and stay off a substance. This was actually developed, I think it was in the 1930s, by some recovering alcoholics who were trying to find help in the community, couldn't find help to support them through getting through and recovering from their addiction, very much wanted to recover from their addiction. They developed the 12-step program, and to this day, it still has the best reputation for helping people to overcome their addiction, whatever it may be, and remaining free of the addiction. So they're encouraged to go to a 12-step program. All the people we talked about today will be encouraged to go to 12-step programs. There are some drugs that can help with the symptoms of recovering from an opioid addiction. Remember, we said that cravings, psychological dependency, and the desire to not feel terrible is what keeps people wanting to take the drug. And so if we can give them a medication that is a long-acting opioid, like methadone, it doesn't give the peak, so it doesn't make them high, but it keeps them from having severe withdrawal symptoms. It helps them feel decent so they can function in life. And then buprenorphine is also another therapy that can be used to help with this. And the film that you're going to look at today as part of your learning activities is going to explain both of these drugs more thoroughly and how they work and why they help people who are recovering from opioid addiction. Any questions about opioid addiction before we move on to heroin? I am relying on that film to give you quite a bit of information on opioid addictions. It's very well done, very articulate, and I think you'll find it very interesting. Heroin is also an opioid, and it's sometimes called the poor man's opioid. People start out by getting stuck on their prescription medications, and then they run out of their source of the prescription medications and turn to heroin, which is just a street drug, which is an opioid. They're one and the same thing chemically. And therefore, they can get it at a lesser price, and they can get what they need to remain addicted to this drug. Like all opioids, it can be taken orally, snorted, smoked, or injected. And there are what are called dime bags. This is the way that they can be packaged to be sold. And they're in little plastic bags that if the police raid a house, sometimes people will try to hide their drug supply by swallowing these dime bags. Then the police bring them into the ER, and the patient gets to receive Golightly, which is kind of a misnomer. Golightly is a very high salt fluid that causes your whole GI tract to clear out. It's what we give people before a colonoscopy sometimes. And it clears out the entire GI tract, and hopefully the person then evacuates the dime bags. That becomes the proof that's collected as part of their drug case. This is the challenge. If somebody swallows these bags, what's to say that they won't actually, start getting dissolved a little bit by the gastric acids, and there could be a leak, and suddenly you have a major overdose of all this heroin in somebody's system. Or maybe the bag wasn't sealed completely, and now there's a large amount of heroin in the GI tract being absorbed. So watch these patients very closely, because if there's any reason to think they've swallowed their drug to hide it from the police, it's not safe within the GI system. It could it could cause a sudden overdose if something disrupts the intactness of the packaging. Stimulants. So those were our CNS depressants. We had alcohol, we had benzodiazepines, they're a CNS depressant, and we had opioids. Now we have stimulants. So stimulants are things that, wake up the brain, get us going. And the two most commonly used stimulants are caffeine and nicotine. But there are other stimulants as well that are more potent and typically really highly associated with addictions. So amphetamines like meth, speed, crystal, ice, ecstasy, pep pills. Synthetic stimulants called bath salts, and there are lots of pretty names that are used for these. And let me just comment on this. Some people are not aware of what we mean by a synthetic stimulant. Anytime the word synthetic is used before the category, what it means is that people in various places of the world are literally cooking up synthetically, making these drugs in a lab somewhere, and then selling them on the internet for use. The challenge with these synthetic stimulants, and in a minute we're going to talk about synthetic marijuana, is that they're constantly being changed chemically slightly from one to another to try to stay ahead of legal issues, and they're quite unknown. They're often very potent, but the user never knows exactly what they're getting because one batch doesn't necessarily match another batch. Or if you buy it from one group of companies selling it versus another, it's not a match. It's not like there's a formula out there that everybody uses that's uniform. It's very much whatever that lab happens to be doing. And that's very unpredictable. And so people who use these products sometimes think it's great, and sometimes they're so potent they have really bad experiences with them. And it's very uneven. It's very unknown what's going to happen when people take these substances. Now, if you're not aware, synthetic stimulants are called bath salts because they're trying to evade legal issues with it. So you all know that, if you go to Bed Bath & Beyond, you can buy bath salts, and they're very lovely things you pour in the bath. It gives a lavender flavor, or lavender scent, rather, and it's soothing, and that's what it's intended for. Everyone knows who's buying bath salts on the internet that when they look at the label, it actually talks about how this is going to create, they talk it up as if it's a true bath salt. But everybody knows it's not really a bath salt. It's not something you're going to put in the bathtub. It is something that's going to be snorted or smoked or used in some other way to as an addictive substance. So it's just a term used to try to skirt the law. Non-amphetamine stimulants or diet pills and Ritalin. So Ritalin, you recall, is used for our ADHD kids. And it is a drug that is sometimes displaced to other people. And so that's something to be aware of. Unfortunately, sometimes mothers use it. They use their children's Ritalin because it gives them an energy boost. It helps them lose weight. And so they think it's a good thing, and they get addicted to their child's Ritalin. And then cocaine also falls under a stimulant. Okay, caffeine we're not going to talk much about. I just want to comment that caffeine is the most common stimulant used. It's very socially acceptable, and they are something that is considered benign and not a problem. Unless you're a teenager who doesn't use good judgment. And you can be sure that teenagers seem to do things to the extreme. So one popular thing to do is to see how many very high caffeinated energy drinks a person can consume in how short a period of time. And of course, if it's a small framed person and they're drinking a ton of caffeine in a short period of time, they actually can get themselves into physiological problems, sometimes with heart arrhythmias, and end up in the ER. A particularly scary thing that sometimes teenagers will do with caffeine is that they will mix it with alcohol. And that can be very dangerous as well, and then they'll end up in the ER. Think about that. A ton of caffeine, which is a stimulant, and alcohol, which is a depressant. The poor body can't figure out what it's supposed to do. It creates all kinds of problems. So this is the only thing we're going to comment about caffeine. It's widely used. It's not considered a problem unless it's misused in some ways like this. Nicotine is also going to be the, this is just saying what the symptoms of caffeine withdrawal are. So we all know, some of us, we are addicted to caffeine, and we know if we go without it for a couple of days, we experience these symptoms. They are usually self-limiting. You don't come to the ER for it, and so it's not usually much of a problem. Okay, nicotine use disorder. Nicotine is considered a CNS stimulant, but it's actually a drug that's really quite unique. and has other properties because nicotine actually works on the nicotine receptors within your body, and you have many nicotine receptors throughout the body. It is highly addictive and accounts for much of the mortality and comorbidities associated with addictions. So, in other words, people who have an addiction to something else often have an addiction to smoking as well. It's considered one of the hardest addictions to overcome. So, give me a couple of reasons why you think this is considered harder to overcome than other drugs of abuse might be. Oh, wow, Braden, I'm just now getting a chance to read your comment of the dysrhythmias caused by energy drink overuse. So, yeah. And yes, smoking, nicotine is easy to access. So again, something that's easy to get is going to be more used for an addictive purpose. It's also very habitual, and it's not considered illegal. And for many years, until maybe the last decade or so, it was also very normalized in our society. And then as we've kind of gone on an anti-smoking campaign, it's become less so. And we're going to talk about e-cigarettes in just a minute, a little bit more, Alina, because that is an important thing for us to know about as well. So thank you for bringing that up. One of the biggest things that makes nicotine so hard to overcome is that idea of craving and memory cues. Remember, that's the psychological addiction. Think about it. If you're a smoker, you haven't smoked all night long, so when you wake up in the morning, you're starting to go into a little bit of withdrawal. And so to avoid those negative feelings of withdrawal, you get up and you have your first smoke. You go down to breakfast, and with your cup of coffee, you have another cigarette. And then on the way to work, while you're driving, you have another cigarette. Then on your first break, you have another cigarette. At lunch, you have your cigarette. Afternoon break, driving home. When there's stress at home, you have another cigarette. You have a cigarette before going to bed. So think about it. It is a high dose drug because you're using it frequently throughout the day. And now you've got memory cues to all of those things. The first thing you did when waking up was reach for a cigarette. So now when you're trying to stop and you wake up, the first thought you have is that you should have a cigarette. So you have to overcome it then. You go down to have breakfast, you pour yourself a cup of coffee. And now there's that memory cue. I'm supposed to have a cigarette with my cup of coffee. So every time I have a cup of coffee, I have a craving for and a memory clue reminding me that I should have a cigarette. And you can see that if you are smoking 8, 12 or more cigarettes a day, you have that many memory cues throughout the day to overcome when you're trying to quit smoking. And this is one of the reasons it is considered so difficult to stop smoking. And we just have to really, I think, have a lot of empathy and support for people who are determined to give up smoking, because it is really hard to do. And it's something that they need a lot of support with. Now, Alina is saying, I think especially with e-cigarettes, it's a high dose of nicotine, so it's easier to become addicted to fast. And e-cigarettes, interestingly, have quite a history and story. They were actually started, it actually been around since 1965, but they didn't take off until in the 2000s. And the idea initially was as a method of trying to help people stop smoking, so that the e-cigarette would replace smoking and you would technically have less episodes of smoking and therefore overall have less nicotine. And depending on how your e-cigarette is prepared, it may or may not have nicotine in it. You can have e-cigarettes that are just the various flavors. Most e-cigarettes do have nicotine that are commonly used. And then e-cigarettes can also have other substances of abuse in it. Nearly anything could be used, but marijuana is becoming something that is also being used in e-cigarettes. E-cigarettes are a way of nebulizing or vaping whatever the drug of choice is. And so one of the biggest challenges with this is that even though it's intended originally as a way of cutting back on smoking and helping people get off nicotine. Because it does have nicotine in it, it depends on the individual. There are some success stories with it, but we also have stories where people have simply started using both. They keep their cigarettes and they use e-cigarettes because there's limits where you can smoke, and sometimes those limits don't apply to all the e-cigarette sites as well. And people like them. And so they are adding that to their nicotine intake instead of actually cutting down. The greatest concern, public health concern about e-cigarettes is we're afraid that it's attracting young people to start a nicotine product. Because they have a lot of flavors and the vaping is, become quite popularized, it's attracting young people. And that's the concern, is that it might get people started on nicotine products and or other drugs of abuse, whereas they may not have done that in the past. Therefore, laws have been set up to make it illegal to sell vaping products to children under the age of 18. So there's a lot of information about e-cigarettes and a lot of controversy about them, actually. But they are, as a general idea, something that needs to be assessed well for our individual patient. How are they using it? How often do they use it? What's their dose? And is it becoming something that is being abused in a way that falls into our definition of addiction or substance use disorder? Smoking cessation, like we said, it's very tough. And there are a number of medications that are used to help people start smoking less and ultimately stop smoking without having as many withdrawal symptoms, because withdrawal symptoms feel terrible and often is what triggers people to relapse and go back on. So if you can limit their withdrawal symptoms, then you can hopefully help them with their craving and memory symptoms, and hopefully they can decrease and ultimately get off using the nicotine products. This is an uphill battle. We need to be very supportive of people who are attempting to do this. It's not uncommon for people to try and relapse a number of times, not only with cigarettes, but with any drug addiction. So we need to be there for them for the long haul and not shame them when they have something that causes them to have a setback, but to encourage them to move forward, take with them what they learned the last time, and to keep trying until they can gain more success. Very challenging problem in our society. Nicotine withdrawal, I've kind of alluded to this already, but it's miserable. They feel depressed, they can't sleep, they're irritable, anxious, frustrated, can't concentrate, increased appetite with weight gain. Many people smoke rather than eat as an emotional release. And so when they stop smoking, they start eating to meet their emotional needs and they put on weight. This can, make it more difficult for them to stay with their good intentions. Okay, methamphetamine is a true central nervous system stimulant, and it is considered the most powerful, potent stimulant. It's called poor man's cocaine because it has a half-life of 19 to 34 hours, as compared to cocaine, which lasts only about 3 to 6 hours in your system. So if you want a high and you want it to last a long time, meth's what you want to use. The challenge with meth is that it is incredibly potent and it really hijacks the brain. And it quickly turns into, like all addictions, initially you get high with it and it feels great, but very quickly it backs off. And instead of feeling high, you have to take the meth simply to not feel terrible symptoms of withdrawal. So you keep taking the drug to prevent feeling awful. And they feel really awful because meth is so potent, it depletes the brain's natural ability to make its own dopamine. And so the only way to have dopamine in those pleasure centers is to take the meth. And so when you stop taking the meth, your brain's left without this dopamine, and it takes a long time for the brain to recover. We're talking a year or more. People who've recovered from meth say they never really feel that great again. And they have to be motivated to stay free of the meth based on other values, like wanting to keep their relationships, wanting to not lose child custody, not wanting to be in legal problems, those types of things. It's a really rough drug and really life-changing for people who have it. Sometimes meth is, especially here in the West, where our houses are spread out, some people will make their own meth in their home, and lovely internet, you can just go on the internet and find out how to make meth in your house. It's extremely dangerous because it has many cancer-causing byproducts. So in the house where meth has been made, those cancerous byproducts actually get into the walls and the floors. And so one thing you should do before you buy a new house is actually have the house checked to make sure it wasn't used as a meth lab, because if you move into it, it can look perfectly clean, but the chemicals will be seeping out, and people have gotten very, very sick by living in houses that have been used as a meth house in the past. Some of the ingredients that are used are pseudoephedrine, antifreeze, Drano. Now, I think that's a great idea. Let's shoot up with some antifreeze and Drano in our bloodstream, right? Iodine crystals, which is used by vets to treat hoof rot disease in animals. So I don't know who came up with this combination, but it is very, as you can imagine, toxic to the body. So the physical symptoms, the behavioral symptoms, and the mental symptoms of being intoxicated are related to the fact that your CNS system is off the charts, overreacting to everything. You have significant weight loss and abnormal sweating, shortness of breath, nasal bleeds from snorting it, sores that don't heal. They often call these meth bugs, where they just scratch and scratch. They can feel something under their skin. It drives them crazy, and they just pick and pick until they have big holes in their skin because they can feel these bugs under their skin. Dilated pupils, decayed teeth. They withdraw from family, change their friends. They don't have an appetite. They're very irritable and careless. And when they're intoxicated, their central nervous system is awake. Think of, having a ton of caffeine on board and that you can't sleep, right? Well, meth is far more potent than that. And so these people cannot sleep for 24 to 120 hours. Once they finally do go to sleep, once they start withdrawing from it, they'll sleep for a day or two at a time, because their body is so sleep deprived that it takes that long for it to start to recover. They're just interested in previously enjoyable activities. They are paranoid, anxious, nervous, agitated. Just think what it would feel like to have that much stimulant going on in your body. No wonder you're so agitated. They can hallucinate, have delusions because of all that big dopamine dump, and it's such a significant dopamine dump. This is a pretty intense and really bad drug to have in your system. These are some before and after pictures of people. And it just shows the tragedy of using this particular drug to abuse. And you can see on the woman's face in the first picture there, she's got a Band-Aid over her cheek. She's got some of those meth bugs. And the gentleman next to him has scratched holes. And yeah, so this is pretty intense for people. Now, someone has their mic on, I'm not sure who it is. So you might want to pay attention to that. So let's see, I don't know if I have the ability to mute that person. Oh, I do. I just learned a new thing. So, okay. Methamphetamine withdrawal is going to, of course, be the opposite. So with intoxication, it was a CNS stimulant, so you were way high. And now with withdrawal, it's going to bottom you out way low. And so that crash occurs within 2 to 4 days of the last dose because it was had such a long half-life. They feel fatigued, depressed, nightmares, headache, sweating, cramps, hunger, wild hallucinations. These people are sometimes brought into the ER, restrained by police because they're just out of control. out of control and have to be restrained for their safety until we can get them through the withdrawal. They're going to be given benzodiazepines because they are so, because of those wild hallucinations, to try to calm that dopamine dump and the wild hallucinations that are associated with it down, and until they start feeling a little bit more in control. And then supportive therapy and rehab, like we do for all our drugs. Cocaine is another CNS stimulant. Ecstasy is as well. So they're pretty much the same. If you know the category, you know the signs and symptoms. CNS stimulant, too much of the stimulant symptoms. Withdrawal, the opposite. Ecstasy is, cocaine is interesting because if you snort it, it damages the blood vessels in your nose because it's a powerful vasoconstrictant, and it can actually cause necrosis inside your nose, and so they can actually have a hole between the septum of their nose permanently, disfiguring their face from having snorted cocaine repeatedly. Ecstasy is marketed to youth. So, people who sell drugs are interested in making money, and they are targeting people younger and younger, trying to get them addicted, because once addicted, it's so hard to overcome. So these are pills that are marketed to young people, and they look like candy, and they have popular imprints on them of popular culture, like Harry Potter for kids or whatever other Simpsons, things that kids might have an interest in. And when youth go to places where there's ecstasy parties, they do what's called stacking, or doubling the dose of the pills that they take at the party. And the stimulant the intoxication of this causes them to develop a high fever. And they're so hot at these parties that they start drinking a ton of fluid because of their fever. And they can drink so much fluid, they actually dilute their sodium level to the point where they have major seizures. They can also have liver failure, cardiac problems, serious muscle breakdown with myoglobin building up in the kidneys, leading to permanent kidney failure. So these are pretty scary drugs. Bath salts we already talked about. These are made synthetically, so they're just chemicals that are being made in a lab somewhere, packaged up, sold over the internet. They're always claiming that they're not intended for human consumption, but the buyers always know what they are and how to use them. They have severe intoxication. It's a strong stimulant. People can have clenching of teeth where they actually can't open their jaws, severe tachycardia, psychotic, paranoid, again, that high fever, coagulability, your blood clotting is fouled up, and liver dysfunction. So various serious side effects for these as well. Okay, any questions about stimulants before we go on to cannabis use disorder? Okay, so I hope you're seeing the pattern that we're trying to repeat. How do you know what the symptoms of intoxication are? How do you know what the symptoms of withdrawal will be? And what will we as nurse do for that? Now let's talk about cannabis use disorder. Cannabis is a hallucinogen. Cannabis is marijuana. It's the medical name for marijuana. It's second only to alcohol as the most widely abused drug in the U.S. and is becoming more and more popular as it gets legalized throughout the United States for medical use and in some states for recreational use. Its smoked today is more potent than when you had the marijuana plants in the 1960s. It was very popular in the 1960s. But the potency of that dose in the 1960s was far less than the potency of marijuana that is grown today. Marijuana if it's grown inside, it has to be grown in a very hot and humid area. And so if police raid homes where it's being grown, and this is happening less as it's become more available legally, that they have to wear full body protection when they go in there because cancerous spores are found on these marijuana plants that are raised in these confined spaces. And so police officers have to be protected from that. synthetic cannabis. So synthetic means it's man-made. And the name for synthetic cannabis is called spice. So once again, what happens is people throughout the world make this chemical in a lab, and then they want it to be delivered to people in a way they're used to seeing cannabis delivered. So they spray the chemical on a plant. Nobody knows what it's plant. Something they can grow fast and easy. It's not marijuana, it's a plant. Again, plants have properties, they have chemical properties, and we have no idea what plant this stuff is being sprayed onto, and it probably changes. And so it's sprayed onto it, it's dried out, and then it is packaged up and sent out. Once again, trying to avoid legal issues, it's always advertised as not intended for human consumption. But of course, the purchasers, that's exactly what they're going to do. Now, spice is, because it's synthetic, can be made very, very potent. And so, like all synthetic things, there's a great unknown about it. We don't know how strong this dose or this particular batch is going to be compared to the batch you buy next week off the internet. And so people have very varied responses to spice. Sometimes they think it's great, and sometimes it's terrible to them, and they report having terrible hallucinations and problems associated with it. The unpredictability of these synthetic agents is what makes it scary to healthcare providers, because if they show up in our ER, first of all, we have to figure out what they've taken, which they may or may not disclose to us. But even if they tell us, we don't know exactly what's in this batch and what exactly its compounds are and what exactly is going on. So it makes it difficult to treat them. Another thing that drug cartels do is they like to keep track of where their product goes. So whether it's spice or whether it's bath salts or whether it's anything else that they're selling, often over the internet these days. So for example, if they're selling heroin, they might lace it with a little bit of methamphetamine, just a tiny bit, to make it a little bit more addictive, but because that makes it traceable. And so the drug cartel people want to see how successful they are at getting their product across the country. So they sell it, they get it out and use, and then they get some back from end users. They test it in the lab to see if it has their chemical marker on it, which can be sometimes a very potent drug that's going to make something even more high risk to the patient and also more addictive to the patient, so they'll want to use it more. Sometimes it's just a chemical, doesn't seem to have much effect on the product, but they have some additional chemical in there, so they can figure out where their drugs went. Was it successful in getting it into the middle America, or on the East Coast, or on the West Coast? And that's how they can figure out how well their drug is being dispersed throughout the country, our country, and other countries. So they may advertise that it's something, but it doesn't necessarily mean that's all that's in it. And what they put in may or may not be benign. So it's a very scary thing. Cannabis intoxication. So first of all, with cannabis, because it's a plant, and many people perceive it as natural. Many perceive that, marijuana really doesn't have any negative impacts, and that people don't really get addicted to marijuana. But that's simply not true. People who use marijuana, it's interesting. People either like it or they don't like it. So people, when they use marijuana, when they've done surveys, they find that there are people who kind of dabble in it, play around with it a little bit, try it, occasionally use it, but don't use it very often. Or if they have people who are really devoted users to marijuana, that they seem to really like it, they use it regularly and chronically. And remember, dose matters. So the regular chronic users actually have the potential of developing a substance use disorder with cannabis. And at the present time, we think there's about 4 million people in the United States who are addicted via the description we talked about earlier with substance use disorder are addicted to marijuana. So it is a potentially addictive substance, and it does have, like any drug, it has side effects, and it has potential for intoxication and withdrawal. So what would be the intoxication symptoms? Well, this is a hallucinogen, and we're going to talk more about the cannabinoids that go into the marijuana plant in just a minute. THC is the cannabinoid in the plant that gives it the classification of a hallucinogen, meaning that if people take it in larger amounts, they can actually give themselves a high, feel euphoric, they can feel anxiety associated with it. They have perceptual changes. It's a pretty unique perceptual change, meaning that they sense that time slows down, that the world's passing in slow motion. This can impair their judgment and is a concern for people who are driving using marijuana because they perceive the world is going by slower. They often respond more slowly to critical situations when driving. They can have impaired judgment, impaired motor coordination, and then, of course, like all people who are abusing drugs, they withdraw socially. That's part of what makes it a substance use disorder if they're using a lot of it. They withdraw socially to spend more time getting their next dose. If they're using very high doses, they can have red eyes, dry mouth, tachycardia, hallucinations, and increased risk for injury. So that's what intoxication would look like. Withdrawal would occur within the weeks of stopping the drug. Now, marijuana is very interesting. Unlike most drugs that are cleared primarily through the kidney, marijuana is stored a lot in the fat and often is cleared through the GI system. And so this means that it stays in the body longer, and therefore it may take a little while longer for us to see symptoms of withdrawal occurring. They can be irritable, angry, aggressive. They can again have nervousness and anxiety, difficulty sleeping, restlessness, depressed mood, and then some physical symptoms: abdominal pain, tremor, sweating, fever, chills, headaches. So once again, those kind of classic symptoms of not feeling really good as you go through the withdrawal symptoms. So people who are actually addicted and have a physical dependency on marijuana, if they stop using it, they're going to have the physical symptoms of going through withdrawal. Now, this is kind of a good little break time, because what I'd like to do, medical marijuana has become legalized in the state of Utah and is very legalized in other states throughout the country. So as nurses, we need to understand what that means to us and how our practice is affected by that, and what it would look like to be part of dispensing medical marijuana and how to do that appropriately. So that's quite a lengthy discussion. So I'm going to take our 5-minute break right now, and when we come back, we'll discuss medical marijuana and some of the things as healthcare providers we need to be aware of that. So let's take our 10-minute break until, I'm sorry, not 10-minute, 5-minute break. We'll come back in 5 minutes. Okay, welcome back, everybody. So we've just talked about the fact that marijuana is more potent today, the plant is more potent today than it was in the 1960s, and that it does have the ability to intoxicate and cause withdrawal, and that there are a certain number of people who actually are finding themselves addicted to marijuana. And so this is something that is important for the public to understand. Sometimes there's the false understanding that the thought that marijuana is harmless, but it can be a challenge for some people, and it can have physical dependency issues, and it can create some problems. So having said that, we also know that marijuana has potential medicinal purposes, meaning that it can be helpful in certain situations. And there's been a lot of interest in exploring the possibilities of how the cannabinoids that are part of the marijuana plant could be used to help people with particular health disorders. And with that in mind, states across the United States have been legalizing marijuana for medical use and in some cases for recreational use. The controversy comes in this regard. The federal government does not recognize marijuana as anything but it thinks it's illegal. It does not recognize it as a legal substance to use in any circumstance. And so, because the federal government has this law in place, states have become involved in trying to claim, well, that may be what the federal government claims, but within our state, you can use medical marijuana within given parameters that each individual legislative group has decided is going to be the case for their particular state. Now, in reality, that didn't make it legal in the United States, but by tradition, federal agents have not gone after people who use marijuana within states where the state has legalized it. Doesn't mean they couldn't, it's just that that's not been a point of emphasis. So this lack of being on the same page has made it so that there is great diversity among the laws of how medical marijuana is used from state to state. So if you practice here in Utah and get used to our laws here, that doesn't mean you know anything about the laws in Oklahoma or in Michigan or in New York. They may or may not have much commonality. So wherever you go, you need to become familiar with the state laws based on how marijuana can be used there. Now, as nurses, we don't have prescriptive practices. Some of you may be planning to go on to become nurse practitioners. Just out of curiosity, if you're considering becoming a nurse practitioner, type that into the chat room. It'd be interesting to see how many of you are thinking of that. And so as a nurse practitioner, you would have prescriptive privileges. And this would become even more important to you because you would be the one deciding whether or not to give a patient a medical marijuana certification, allowing them to buy marijuana in the state of Utah. For those of us that are not nurse practitioners, we need to understand the laws, we need to understand the principles because we're supporting the physicians who are making these recommendations, and because we need to, as with all medications, we are the double check to make sure things are being done appropriately. So we need to understand how to appropriately use these drugs as well. So when we look at medical marijuana, there are two main cannabinoids in the plant that are being researched and have some evidence of helping with certain medical conditions. Now, there are over 100 different cannabinoids in various kinds of plants. So this is an area of research that really is worthy of looking at to see if other cannabinoids, besides the two we're going to talk about today, may also have benefits to patients with certain medical conditions. The two cannabinoids that we focus on at this time, because we have some knowledge about them, is CBD, which is the non-psychotropic component of the plant. So in other words, it is not a hallucinogen. It is a calming property. High CBD strains can attenuate the effects of the THC, meaning they kind of balance it out. So THC is the other cannabinoid, and it does have psychotropic effects. In other words, that's why this plant is called a hallucinogen. Now, in the plant itself, you're always going to have some combination of the CBD and the THC. People who grow these plants try to make it so that the properties are a little bit varied. They try to make it so some plant strains have more CBD, and they try to make it so other plant strains have more THC. But in the plant itself, there's always going to be some combination of the two. And that combination is going to affect how it affects the person who's taking the marijuana plant. Now, Studies have been done, and we have tried to make it so that they can take strains or oils of the various cannabinoids, so that you really just have CBD as what you're giving the patient, or you really just have the THC, which you're giving the patient. So that's being researched. What happens if we just give one component of the plant and we don't have the person smoke the whole plant? And so research is being done that way. But as I said, there are more things in the plant than just these two cannabinoids. And so there is some thought, and probably accurately so, that sometimes the plant itself is more therapeutic in certain conditions because these two components, CBD and THC, may have some effect on the condition, but it may be one of the unknown cannabinoids or other property of the plant that is benefiting the person that has a particular physical problem. So what we're saying is there's a lot of unknowns. Let's talk about what we do know about CBD. We do know that it is an anxiolytic, which makes you feel mellow. So it's what makes people who smoke marijuana feel like they're more mellow. It has some anticonvulsant effects, and we know that CBD oil is being used as an anticonvulsant, especially in resistant epileptic children. Antispasmodic properties also exist in the CBD cannabinoid, and there is research that indicates this is beneficial for patients who have multiple sclerosis or MS. There's also some antioxidant properties, and there's research going on about anti-neoplastic properties. That is not well defined yet, but there is reason to believe that it may have a role there, and so it's being researched further. THC, what we know about it is that it can have some positive effects for people who are struggling with chronic pain, especially neuropathic pain. So some of you may realize that we have a number of drugs to help with neuropathic pain. Gabapentin is one of them. And what they have found is that usually how this works is physicians will try to use the prescription drugs available, like gabapentin, give those a trial, and if the person does not have good pain relief with those, then they might consider giving a medical marijuana certificate to the patient to see if marijuana would help this person's chronic pain. It has antiemetic properties, and especially is helpful for people who are receiving chemotherapy and are very nauseated. It also has anti-anorexic properties, so patients who with AIDS, we used to see more of this even 2 decades ago when we didn't have good treatment for AIDS, and people when they were dying of AIDS would get into what's called wasting syndrome, where they had no appetite, but their body metabolism was very hyperactive, and so they were losing weight tremendously. And we know that the THC in marijuana helps them to eat more when they're suffering from that condition. Interestingly enough, because of the hypermetabolism, it doesn't help them gain weight, but it does help them to eat more. And then it's considered as a last resort if other medications were not effective due to an increased risk for paranoia and hallucinations, because this is the hallucinogenic property within the marijuana plant. So it's the one that has side effects that would be concerning. So THC is usually a last resort after we've tried the medications on the market to see if they would work better with fewer side effects and with more known predictable outcomes. Okay, so choices for medical cannabis. What do physicians, nurse practitioners have available? Well, interestingly enough, we actually do have some pharmaceuticals. And they're listed here. And it's tiny writing, I can't quite read them, but they're right there on your screen. The various pharmaceuticals. In other words, a physician has been able to, for many years, order marijuana in a pill through the pharmacy to give to patients. And these are the 3 that are available. As I said a minute ago, advocates of people who want the marijuana plant available for medical use point to the fact that these pharmaceuticals have specific amounts of CBD or THC in them, but they don't have all the properties of the plant itself. And we do realize that there are other properties in the plant that may be the thing that is benefiting the person. So advocates for medical marijuana have wanted the plant available for use. And this allows for the possibility that it might be able to help other physical ailments because of something that's in the plant that would be beneficial. But it also creates challenges because it's hard to prescribe a plant as opposed to a pill. The pill is made in the lab and it is exactly what you expect it to be. But when you prescribe a plant, you prescribe a certain amount of unknowns. For example, dosing is very difficult because the whole plant contains some ratio of CBD to THC. And as I said a minute ago, depending on the plant, the strain has differing proportions of those cannabinoids. In dispensaries that are trying to do a good job with this, they actually try to advertise what the dosage of the CBD versus the THC ratio is in the plant matter that they're selling. Some places do a good job of this, other places not so effective. It's also impossible to get consistency between plants even within the same strain of the plant because sun, soil, and seasons affect the ratio of what that plant will actually become. And then we just talked about pot shops vary in how effective and how careful they are in providing information to the end user. Now, there are some unintentional consequences of medical marijuana legislation as it has occurred through other states and is now happening in our state. One of the unintentional consequences is that there are loopholes. Now, when people vote to have these things available in their state, people want it because they want to relieve the suffering of people who do not have better options. They look at the person who's in chronic pain, they look at the person who has uncontrolled seizures, they look at people who are really in distress and they say, certainly we ought to make everything available so that they can have as much comfort and relief as possible. But when the laws are actually written, there are many loopholes in the way the laws are written. And depending on which state you're practicing in, there are guidelines for what physicians should be prescribing this for. And the list of disorders that are allowed to have, I shouldn't say prescribe because you can't prescribe marijuana, you can only certify it because of that legal issue we talked about earlier with the federal government. Physicians can only certify that they are allowed to buy medical marijuana. And the number of conditions on the list that marijuana may help is a large number of conditions. But the science behind those conditions varies tremendously. In some cases, there's good science. In other cases, there are suspected that it might be beneficial. In other cases, we don't really have that much knowledge about it. So the science behind when it should be used and when it should not be used is still lacking. And most of the science, interestingly enough, is coming from other countries where they're doing more research with this because, again, they don't have the federal government creating barriers to figuring out these things as much. Another unintentional consequence is that some physicians who aren't ethical are skirting the law. All laws are written in the sense that you should only be able to get your marijuana certificate, medical marijuana certificate, from a physician who is treating you for the condition it's supposed to help and is following through on your care to see if it really helps, right? An ethical physician would do that. They would rule out other things that might work, then certify the use of this, and then help the patient figure out what dose, what strain, what's benefiting them, and watch them closely over time to really help them get a good therapeutic effect with this. Unfortunately, not all doctors have high ethics, And in states where medical marijuana has been around for a long time, we have what are called doctors in a box or doctors in a van. And the word just gets out. You want access to medical marijuana or you want marijuana, you just go to this doctor. And no matter what you come in for, this doctor just gives you the certificate so you can go buy it. And they don't follow through, and they're not really taking good care of you as a person. So they're not being very ethical. The public doesn't always understand that this is a drug, and therefore it has potential problems. And so we're having safety issues. For example, there are edible cannabis, which in the form of pills that people can eat. And people don't understand how edibles differ from smoking. So smoking is the fastest way you can get a drug to your brain, even faster than IV, because it hits all those capillary beds in your lungs and you immediately get a rush to the brain of the drug. That's another reason nicotine's so hard to overcome. And so if you smoke the plant, you get an immediate effect from starting to smoke the plant. However, if you eat the medical marijuana or cannabis, how long does it take for you to absorb and start getting the effect of an oral drug? Somebody throw that out for me. Yeah, 20 minutes it starts. You might not get the full effect till 30, 40 minutes, right? And so there's a delay. Well, the public isn't well educated about pharmacokinetics, and they may or may not understand that they need to wait a little while after they've taken their oral dose to get the impact of the oral dose. So if they haven't been well educated by their healthcare provider or by us as nurses, they may take the pill and wait 5 minutes and go, hey, this isn't working, and take some more. Oh, it's not working, and take some more, and inadvertently overdose themselves. Or cannabis has side effects, and people don't realize this, especially that change in time perception side effect is something that creates problems and that people need to be aware of, so they'll take appropriate safety measures for driving. Now, one of the common sense things that doctors encourage is that if you're taking medical marijuana routinely for a health problem, that you shouldn't be driving until 24 hours after your last dose. Now, that's an educated guess. There's still a lot of research that needs to be done about how long that marijuana is in your system and could be impacting your reaction times when driving. Okay, other things that you need to be aware of, cautions. So if a physician is going to consider giving medical marijuana, they should definitely not be giving it to patients with bipolar disorder, schizophrenia, or a family history of mental health disorders, because this could lead to worsening of the condition and or a permanent psychosis. So remember earlier in the lecture, I commented that people who take marijuana in this case, but other illicit drugs as well, get a dopamine dump. So people with a family history of mental health disorders, especially mental health disorders like schizophrenia or bipolar disorder, already have the genetic predisposition for this condition. So if you give any drug, including marijuana, that causes a dopamine dump, you could actually trigger that condition to begin. And once the drug is out of their system, they still have psychosis. It becomes a lifelong problem. It's very sad. The estimates are around 20% of people, 20 to 25% of people with a in the vulnerable population are converting to their mental illness with the use of marijuana. Now, the challenge is you say, well, I don't have that as a family history. The challenge is most of us don't know our family histories that well. Think about your family history. Some of you may know whether you have schizophrenia or bipolar disorder running in your family. But many times, especially in the older generation, there was such a taboo about having any sort of mental illness that euphemisms were used, like Grandma Sarah had a nervous breakdown, or something of that nature. Well, what does nervous breakdown mean Does that mean she was highly anxious? Does that mean she had depression? Does that mean she had psychosis? Those kinds of things don't tell us anything. So the fact that we don't really have accurate, really good family histories about mental illness because of the stigma associated with mental illness encourages us to communicate with our patients about this connection of using marijuana and family history of mental illnesses and the concern that we should have to be careful there. Avoid if the patient is recovering from another addiction. This only makes sense. Marijuana is addictive. So if you already have other addictions and you start using medical marijuana for something, chances are very good that this will become one of the 4 million people who become addicted to the marijuana. So we don't want to set them up for yet another addiction. Elderly patients or arthritic patients may not have the dexterity to weigh and roll the joint or prepare a vaporizer. So remember, the plants are often baked and or smoked to get the best effective, quick benefit. But if you're elderly and you can't do dexterous things, you may not be able to give yourself the medication. So you'd have to consider an edible form or another form of giving them the cannabis. Smoked cannabis impact is associated with dose, so just like we've said all along. How frequent and how long has the patient been using the cannabis? If a person has an underlying problem with their lungs, we are concerned because the methods for smoking always have some delivery system for the mechanism of smoking. Now, we do know that people who smoke or vape marijuana do it less frequently than smokers, right? We talked about a minute ago how smokers might have 8, 10, 12 cigarettes in a day. If you're vaping marijuana, you may only be having a dose or two a day. So you have fewer doses of inhaling something into your lung. Having said that, however, if you already have an underlying lung problem, there is the belief that it increases the risk of bronchitis or may exacerbate an already existing respiratory problem. So think about the person's lungs before deciding that it's appropriate for them to smoke the marijuana or vape the marijuana as a way of getting that delivered to their body. Long-term impact of smoking marijuana is simply unknown. There is not enough research to know. But there is ongoing research. We'll check back in 20 years and we'll have a more definitive answer to just how big of a problem or not big a problem it is. Immune-compromised patients are more likely to get sick secondary to any spores that have been on a plant. And so these patients who have transplants, they have to sign releases claiming they will never smoke or use marijuana plants because it could really create a significant problem for them. Allergies to cannabis. Now, I thought this was very interesting. I didn't know this until I was reading up for the presentation. And some studies show that as many as 8% of people are allergic to cannabis. Isn't that interesting? It's a fairly high percentage is kind of an interesting thing. So just like everything else, we need to know allergies. And if they have had an allergic reaction to cannabis, it needs to be in their chart. And this would contraindicate their being given it as for medical purposes. It's also contraindicated in pregnancy and is contraindicated for males attempting to reproduce as cannabis has negative effects on the sperm count and quality. So this is something to be aware of with their reproductive lives. Now, even though it's technically contraindicated in pregnancy, it is interesting that there are those who are experimenting in various ways, thinking that there may be some benefits in some ways. So these are the cautions right now that the medical field recognized should be followed. Okay, so potential harms of medical marijuana. So poisoning of children and pets, so just like all medications, if you are going to certify that they can have medical marijuana, you need to educate about how to keep it safely stored in the home so children and pets can't accidentally get into it, especially if it's an oral form and the child thinks it looks like candy. Motor vehicle accidents due to this delayed reaction time, which lasts longer than the perception of being high. So you think you no longer have marijuana in your system, but your reaction times are still slow for a period of time after that. As yet, there are no reliable roadside tests to determine cannabis impairment. So they're doing research into this. And as I said earlier, as kind of a general rule of thumb, it's suggested that they not drive for 24 hours past their last dose. Pesticides, because this is a plant, pesticides are used on the marijuana plants as part of the growing process. And it's interesting, there's now a demand for organic plant pot, as many people don't like the idea of being exposed to pesticides. Mental illnesses. Right now, it's contraindicated to give medical marijuana to people with a mental illness. Again, because of that possibility of it triggering psychosis that they don't recover from, and also because it may exacerbate their underlying problem. So it is, we're shying away from that for using it for mental illnesses at this time. There is research going on in this area, so we'll stay tuned and see if something changes. But right now, medical doctors are encouraged not to treat mental illnesses with medical marijuana. Because it can precipitate that psychosis, it may be acute or self-limiting when the drug wears off, meaning that they have an intoxication psychosis, or it can become permanent and may lead to schizophrenia for a lifetime in some of our vulnerable populations. Effects on youth, lack of motivation. So one of the things about marijuana is that it makes you feel mellow. It's one of the reasons people like to take it. But it also has a tendency to make you feel so mellow, you don't feel as motivated about things. And young people who have declines in their grades, one of the things we want to make sure is that when we do a history on them, we find out just how much marijuana they may be using, because this might be the reason their grades are going down. They're just not motivated to study. They also have structural changes taking place as they grow. And if they take marijuana before the age of 25, it has been shown that, again, dose dependent, heavier users for long periods of time can actually permanently lower their IQ, and it's unrecoverable. Chronic users as adults also experience this lack of motivation and can have unrecoverable cognitive decline. Again, that's usually the frequent chronic user. Okay, so that was a lot about medical marijuana. I'm going to give you resources at the end of this that give you the resources to our state laws so you can investigate them further. Just to kind of highlight some last kinds of drugs and how they're used and abused are inhalants. These are usually used with young people who can't get their hands on more serious drugs. So they'll inhale things like fuels, solvents, adhesives, paint thinners. This is called huffing or bagging. This little boy, I don't know if you can see too well in the pictures, but his lips are just humongous. It's swollen up his lips. And remember I said that when you inhale something into the lungs, it hits all those capillary beds at once, and the drug goes immediately to the brain. That's what causes the euphoria, why this method of delivery is often preferred to get that high quickly. But it also means that those dangerous chemicals are going straight to the brain matter. And as you can look on the side here, you can see cerebral atrophy, degeneration, airway distress, nausea, vomiting, and death can occur with this. So it's a very serious thing to educate children about. Children also get their hands on over-the-counter stuff. One thing that's considered popular is using dextromethorphan. I almost got that out quickly. But this is what's found in cold medicines like Robitussin. And this is called robotripping, where they take 25 times the typical dose of Robitussin so they can get a high. Now, typically, the high itself is self-limiting and they would recover from it. However, as you know, look at your over-the-counter medications. Your cold medicines almost never come as just the dextromethorphan. It is usually mixed with other things like acetaminophen. And acetaminophen can cause permanent damage to your liver. So it's the Tylenol, in these medications, overdosing with the Tylenol that can cause the permanent damage. Another thing that is abused by young people is antihistamines like Benadryl, again, taken in excessively large amounts. And they can have what are called anticholinergic toxicity symptoms. So this little saying on the side is an easy way to remember what these are. Mad as a hatter, hot as a hare, blind as a bat, red as a beet, dry as a bone. These are the symptoms of an anticholinergic toxicity and are what we would see if somebody uses antihistamines. And they take like 25 Benadryl at a time. It's pretty overwhelming amounts to get these highs. Other things that can be abused is nasal or ocular sprays. They have stimulants in them. That's what causes them to be effective, to cause to have the local effect that they want to have when used therapeutically. And all you have to do is go on the internet and find out how to extract that stimulant from those products, and then you have a stimulant that you can abuse. Vicks Vapor Rub, they can extract the main ingredients there and can get high on that as well. And then we've talked about laxative use. That's not really a drug of abuse in the sense that it does not cause a dopamine dump. So it's abused as a way of purging with our eating disorders. Steroids also do not cause dopamine dumps, but they're abused drugs that we want you to be aware of, because young people, sometimes older people, will do this. What they don't realize is that they may build your muscles, but they don't actually strengthen your tendons and ligaments. So you're actually more at risk for injury because you have these humongous muscles that are not, the supportive structures did not enlarge as well. So you're very high risk for injury. And then all the untoward side effects that you can see here too, the long-term use of steroids. So just familiarize yourself with that. The last one that youth may do is very scary. It's called farming. There are other names for it as well, where young people will go to their parent, their grandparents' cupboard, and they'll grab all the medications out of it. And then they bring it and put it in a big bowl in the middle, and they dump them out of their containers. And you have this, array of all these mixed medications. It could be the over-the-counter Tylenol. It could be your grandmother's heart medication. It could be your mother's blood pressure medication. It could be hormone pills. It could be anything you can think of. They dump them all in this container, and then they, kind of like Russian roulette, they go around and they swallow pills and they see what happens to each other. You can see this is incredibly dangerous because the combinations of drugs that could show up in a person's body and cause conflicting information in the body can be overwhelming and can kill people. When I was giving this lecture a number of years ago, one of the students raised his hand. He had a friend in high school who really felt bad about going to a party where this was being encouraged. Just everything inside her, she was really reluctant to do it. But peer pressure, she gave in, she went, she participated in this kind of party. Who knows what combination of drugs she ended up having? She ended up in the ER in a coma and is in an extended care facility today, never having awakened from her coma. So very deadly, very scary. So as parents, along with everything else we're trying to protect our children from, we want to have these, it is so sad, we want to have these conversations with our children. We want to have that communication rapport as they go through their teenage years and even into their young adult years, where you can tell me anything. I'm not going to overreact. That's sometimes hard as parents not to overreact, but we're going to try really hard not to overreact so that they can feel comfortable talking to us. We can educate them. We can steer them in the right direction, that they'll be more likely to listen to us when we say, these things are dangerous, don't go that way. And parents actually do have significant influence on their children, especially if they've been able to maintain that open rapport. Such an easy thing to say in class in 2 seconds. For anybody who's a parent, especially teenagers, you know that that's much harder to do for lots of reasons. But we really want to try to do that to the best that we can and to support them through these years, to have an open communication and really educate them ahead of time about the dangers of participating in especially some of these drugs that are happening very young and yet are very dangerous. Okay, so For the last 20 minutes here, we're going to talk about nursing interventions. So notice we've talked about substance use disorder, which was addiction, substance-induced disorders, which were the physical symptoms that come on because you're taking a drug, intoxication, withdrawal, psychosis, and other things. And then we talked about each of the classifications, what the symptoms were for being intoxicated, what the symptoms were for being withdrawal, and what we as nurses would do to support them. We talked a little bit about medical marijuana and guidance for how that should be used if it is going to be certified. And now we're going to talk about the nursing interventions for caring for people with a substance use disorder. One thing I want you to notice, I've kind of alluded to this several times, is it doesn't matter what substance a person has used. If they have used it chronically and have had a physical dependency on a drug of any kind, whether it's a stimulant or depressant or hallucinogen, sleep disturbance seems to be the withdrawal symptom that is common among them all and lasts the longest. So they can have gotten over all the other withdrawal symptoms and they will have sleep disturbance for months after they finish with the other symptoms of withdrawal. This is hard on patients because you can't sleep. What do you want your doctor to do? Can't sleep, feel terrible, you're exhausted. What do you want the doctor to do? Well, you want him to prescribe a sleep medication, right? Only what's the problem with that? Sleep medications are benzodiazepines. They're an addictive substance, and we're setting you up into an addictive process again. So we're going to try to use all those sleep hygiene things that you learned in 1030 rather, to try to help them through this and reassure them that it will eventually settle down and they'll be able to sleep again. When we're caring for somebody who has a substance abuse problem, we need to do a self-inventory. People have different views about substance abuse for lots of different reasons. We've had personal experiences. My grandfather was alcoholic. That plays a role in how my family views things. You may have situations like that as well. Other things, as we talked about, our views vary based on our life experiences and other kinds of things. And sometimes we need to take a self-assessment and recognize that we may have feelings about this matter. And remember, we want to treat all our patients with a positive regard, an unconditional positive regard. So we want to make sure that if we have some things that are making it difficult for us to treat the person, that we work through that ourselves so that when we treat our patients with addictive problems, we can give them the best care, treat them with kindness, matter-of-factly. We have to hold them to what they need to do, but do it with that positive regard. People have made mistakes, but they themselves are very valuable, and we need to keep that in mind when we're providing care for them. I don't know about how many, we're running out of time, but you can put some in the window if you have stories of this, but sometimes you see nurses not treat patients well, and you're like, why would you not treat somebody well? And sometimes just realizing that you're doing something helps you to do a better job in the future. So self-inventory is very important. Risk for injury is our high priority, right? So if a person is abusing substances, our very first thing that we're going to take care of is we're going to make sure they stay safe. We're going to obtain a drug history, and we want to do it in a matter-of-fact, non-judgmental way so that it's more likely that they'll tell us the truth. Now, having said that, drug abuse and lying go together. Hiding goes together. So if we come across as judgmental, we're for sure going to get the lie. But if we can be matter-of-fact and non-judgmental and try to build that trust and rapport, we're more likely to get truthful information. Having said that, though, because drug abuse and lying go together, we always validate what they're saying by doing urinalysis and the drug tests to see what drugs may be in their system. We observe their behavior, and we make sure that we keep their rooms safe. Denial. Denial is the number one thing people with addiction do for a very long time. And so, if I deny I have a problem, then I don't ever have to address it. If I can blame the problem on somebody else, I never have to address it. So we need to build a rapport with the patient. Again, convey that acceptance, provide knowledge, but also not let them get away with excuses. We're going to confront with caring and not allow rationalizations or blaming others or projecting the problem onto others. I could quit if I wanted to. Okay, let's see if we can help you accomplish it, rather than just take that as an excuse. And encourage participation in groups. This is hard. What we're asking people to do is hard, and they need as much support as possible. And often when they participate in groups of people who get it because they've had similar experiences, this can be very helpful to them. Ineffective coping. We do have to set limits. We do have to be able to help them see their options, their limitations, and try to reinforce behaviors that are going to be healthier. Family members often need help with this. Family members kind of back into a codependent role. Codependency means that I can't be happy unless you are happy. So let's suppose my spouse is the person who is addicted to something. You love your spouse. It's starting to create problems. So you start making excuses for them, to the kids, why the spouse doesn't feel up to joining us on the family excursion tonight, or going to the movies, or going to dinner. Start making excuses for them. They're going through withdrawal symptoms Monday morning. They feel terrible. You call the boss. Oh, I'm so sorry. I think he's got a little bit of the flu and he'll be in tomorrow. You start making the excuses. You start buffering the person's life to try to protect them from the consequences of their addiction. Now, you're doing this out of love, but in reality, what's happening is you're developing a codependency. You're not having appropriate boundaries. And oftentimes, people who are addicted, in their denial, it's not uncommon for them to project and blame. So not only are you trying to buffer for them, but they're blaming you for everything that's going on that's bad, right? I wouldn't need to drink if this or that or the other about you. And so the person who's codependent is finding themselves trapped and in a no-win situation. And so working with family members to overcome codependency, to recognize the difference between I can love with boundaries, that is my expression of love, helps them get over being codependent. That's a tall order as well, folks. All of these things we're saying in a couple of minutes, but they take a lot of support from counselors and support groups to be effective and helpful. Imbalance in nutrition, less than body requires. Well, they're drinking their meals. They're using their substance instead of eating and drinking appropriately. So again, basic needs, nutrition, we've taken care of safety, now we're taking care of basic needs. Okay, so does anybody have any questions before I make a last couple of comments and let you get on to that learning activity? This is most definitely a lot of information in a short period of time. However, pay attention to the patterns I keep telling you. If you learn the patterns, you don't have to learn every detail, and you'll be accurate, and you'll know the big picture and how you're going to interact with the patients. As always, please reach out to me if you have questions. I really do want to hear from you. It's hard for us to not be in person when we teach, so we can see your response and if you're getting it. So if something doesn't make sense, please let me know. In addition, getting accurate information is critical. And so this is what we have in front of you right now. Reliable sources for current information is the National Institute on Drug Abuse. I have condensed in 2.5 hours something that literally could be discussed for weeks. There is so much more that could be said. There's so much more that could enhance your knowledge of this. So if you're looking for a resource or you have specific questions, this is a great site to check out. It's very objective. It kind of presents objectively all sides of the story, and it's very helpful to refer to this site as a healthcare provider. As I promised, there are resources for other kinds of things. So Fighting the New Drug, this is a site for pornography is one of our addictive classifications under here. So that's something I didn't bring up earlier, but it's a site for how to manage that. Substance abuse prevention and the alcohol use disorder identification test. This is how you interview alcoholics. So if you have a greater interest in this, these are resources for you. These will not be on your test next week. Only the information in the PowerPoint and on that learning activity will be. But I like to give you the resources in case I've triggered any interest or you would like to delve into it more, because this is an area where you would have an interest or would like to work. The last site there is the Utah Department of Health marijuana laws. It's a site with the Utah government, so it's continually being updated as this law comes to fruition and it starts to be implemented, which is now. So if you have specific questions about our law here in the state of Utah, that's a good resource. That's a lot of information. Any last comments before we're finished? Okay. Again, remember to do your opioid film. It takes, I can't remember if it's 20 or 30 minutes. It's not more than 30. And it's with a little learning activity that goes with it. And that again is due at midnight tonight. And thanks, you guys. You guys are great. You're hanging in there, folks. One more week, one more test and one more presentation. And then we're going into the end of the semester. So you guys are amazing. Thanks for hanging in there. And we'll talk to you soon.